Welcome to MED-MYSTIFY. Hey everyone, let's get ready to absolutely master the cardiovascular system today. We're bringing you an essential, highly visual explainer on cardiovascular pharmacology, and we're zeroing in specifically on antihypertensive agents. We're going to decode all those complex physiological pathways and drug mechanisms that keep blood pressure in check.
It's really this incredible system where pure mechanics meet complex chemistry, and understanding how they interact is absolutely critical for literally any clinical practice.
Okay, let's dive right into this, because how we actually manipulate the body's chemistry to lower blood pressure is just a fascinating puzzle. Hypertension is a massive global health challenge, right? But the sheer variety of ways we can pharmacologically intervene is honestly incredible. We aren't just treating a number on a chart. We're chemically modulating enzymes, receptors, ion channels, and even the central nervous system itself to get the entire cardiovascular system to just relax.
So, here's our roadmap for today. First, we'll look at how antihypertensives actually work. Then we'll move into nerve and ganglion blockers, followed by direct vasodilators. After that, we'll hit some key drug profiles, and finally, we'll wrap it all up with some high-yield exam pearls.
All right, kicking things off with Section 1, How Antihypertensives Work. Let's map out the primary physiological pathways these drugs are targeting.
Let's take a look at ACE inhibitors first. Think Captopril and Lisinopril. Notice right at the top of the cascade here, these drugs literally inhibit the angiotensin-converting enzyme. The immediate domino effect? A sharp decrease in angiotensin II formation. And by preventing that, we're doing a bunch of things all at once. We stop vasoconstriction, we decrease aldosterone, which halts sodium and water retention, we lower ADH, and we drop overall sympathetic activity. All of these pathways basically team up to decrease peripheral resistance, blood volume, and cardiac preload. Ultimately, blood pressure goes down. But hey, pay close attention to that separate pathway at the bottom. ACE inhibition also increases bradykinin. This leads to a boost in nitric oxide and prostacyclin, which hands us even more vasodilation. It's a fantastic double whammy.
Let's move to the next step and see how this builds. We're looking at angiotensin II receptor antagonists now, or ARBs, like losartan. Notice how incredibly similar those downstream effects are to the ACE inhibitors. You get the decrease in peripheral vascular resistance, the drop in blood volume. It all leads right to lowered blood pressure. But the mechanism of intervention is totally different. Instead of stopping the body from making angiotensin II, ARBs just block the AT1 receptors, so the angiotensin II is still floating around, it just simply cannot bind. And as an added bonus, blocking these receptors actually stops cardiac and vascular remodeling, which specifically reduces dangerous heart hypertrophy and fibrosis.
Now we're moving to a completely different mechanism entirely, calcium channel blockers. This is such a brilliant example of localized cellular intervention. These drugs bind directly to and block L-type calcium channels. When you block those channels, you get a decreased influx of calcium ions right into the smooth muscle cells of the blood vessels. And guess what? Without that calcium, the smooth muscle just cannot contract. It has to relax, which leads directly to vasodilation. It's a wonderfully direct, mechanical solution to vascular tension.
Next up, let's examine diuretics. What is so fascinating to me here is this dual timeline effect. First, we see the immediate impact. Diuresis leads to increased sodium and water excretion, which drops your plasma volume, lowers cardiac output, and boom, lowers blood pressure. But then there's the long-term effect. With long-term use, we're talking maybe 6 to 8 weeks, overall body sodium decreases. This actually lowers the intracellular sodium inside the vascular smooth muscle cells themselves, and that leads to the relaxation of those muscles and a drop in peripheral vascular resistance. So diuretics are essentially playing a short game with fluid volume and a long game with vascular resistance.
Moving right along to Section 2, nerve and ganglion blockers. Now we're shifting our focus away from the vessels and kidneys and looking directly at the neurological control of blood pressure.
Now, what's really interesting about this slide is just the sheer vast array of adrenergic targets. Notice those centrally acting drugs? They're stimulating alpha-2 receptors way up in the medulla to actually decrease sympathetic outflow. Then, we have adrenergic neuron blockers stopping norepinephrine release right at the source. And of course, the peripheral targets. Alpha blockers inducing arteriolar dilation by blocking vascular alpha-1 receptors, and beta blockers targeting cardiac beta-1 receptors. That drops heart rate and cardiac output while simultaneously inhibiting renin release. It really highlights just how many different neurological dials we can turn to manage hypertension.
Taking that neurological intervention a giant step further, we have ganglion blockers, like hexamethonium. By blocking the nicotinic, or NN, receptors right in the autonomic ganglia. These drugs completely shut down transmission from preganglionic to postganglionic nerves. Just look at the cascade this causes. You get a total loss of sympathetic tone, causing vasodilation, decreased cardiac activity, decreased renin release, and venodilation. Honestly, it's a massive, multi-system drop in blood pressure. And that's exactly why these are rarely used today, except in very specific, highly controlled hypertensive emergencies.
All right, on to Section 3, Direct Vasodilators. Let's explore the agents that literally force the blood vessels to relax through localized chemical actions.
Right here we have the pathway for arteriolar dilators. Think hydralazine and minoxidil. They cause direct, immediate relaxation of the arteriolar smooth muscle. This directly lowers peripheral resistance and afterload, causing blood pressure to just plummet. But check out the downstream effects. This sudden drop in pressure actually triggers reflex sympathetic activity. Basically, the body panics. It tries to compensate, leading to an increase in heart rate, cardiac output, and renin release, which ultimately causes sodium and water retention. And that is exactly why these drugs are almost always prescribed alongside beta blockers and diuretics. You have to counteract that reflex.
In stark contrast, when we look at drugs like sodium nitroprusside, instead of just targeting the arterioles, these act as a direct source of nitric oxide. The nitric oxide activates soluble guanylose cyclase, which in turn increases cGMP. This single, powerful chemical change causes smooth muscle relaxation in both the arterioles and the venules. So you're getting a drop in peripheral resistance on the arterial side and a drop in venous return and preload on the venous side. It is a highly potent dual-action relaxation that is an absolute lifesaver in hypertensive emergencies.
Let's pivot a bit into Section 4, Key Drug Profiles. We're going to look a little closer at the specific chemistry of some of these key agents.
And this brilliantly illustrates the subtle but absolutely critical differences in drug design. When you compare the chemical structure of Lisinopril to Enalapril, you see they are both ACE inhibitors, but functionally, they have a major distinction. Lisinopril is an active drug the very moment you take it. Enalapril, however, is a prodrug. Its structure actually requires hepatic metabolism in the liver to convert into its active form, enalaprillate, before it can do its job and inhibit the ACE enzyme. Now, truly understanding how a drug works also means understanding its side effects. Let's contrast two completely different medications. Captopril, an ACE inhibitor, frequently causes this really persistent dry cough. Why does it do that? Because inhibiting ACE increases plasma levels of bradykinin, and that bradykinin irritates the lungs. On the flip side, we have Clonidine, which is a centrally acting alpha-2 agonist. Because it operates way up in the central nervous system to decrease sympathetic outflow, its side effects are heavily neurological. Things like severe sedation, drowsiness, and dry mouth. So two very different mechanisms resulting in two entirely different side effect profiles.
Okay, I highly recommend you take a mental screenshot of this slide. Consider this summary table your master key. It neatly aligns the drug class, the precise mechanism of action, and the major clinical uses for everything we've discussed today. From Timolol acting as a beta blocker for hypertension and glaucoma, all the way down to Nitroprusside acting as a nitric oxide donor for those acute emergencies. It's really all about matching the right physiological lock with the exact right pharmacological key. Finally, let's wrap this all up with Section 5, High-Yield Exam Pearls. For all the students and focused learners out there, wake up! This is our rapid-fire, high-yield exam prep. Here is the first set of pearls you need to commit to memory. When you're dealing with pregnancy-induced hypertension, Methyldopa is the preferred safe central alpha-2 agonist. Got it? Next, regarding Captopril, it's unique because it has the shortest duration among ACE inhibitors and contains a very specific sulfhydryl group. That SH group is heavily tested on exams because it's specifically associated with taste disturbances and skin rashes. Lastly, sodium nitroprusside. It is the absolute drug of choice for hypertensive emergencies, but it requires incredibly careful clinical monitoring due to a very real risk of cyanide toxicity as it metabolizes.
So, the crucial point here is that unique side effects often become your exam questions. Take Minoxidil, a potent arteriolar dilator. It commonly causes hypertrichosis, which is just unwanted hair growth. In fact, this side effect is exactly why it was later developed as a topical treatment for alopecia. Crazy, right? Next up is Hydralazine. With prolonged use in higher doses, this drug carries a major risk of causing drug-induced lupus. And finally, Clonidine. Because it so profoundly suppresses central sympathetic outflow, you must never ever discontinue it abruptly. Doing so creates a massive risk of severe, incredibly dangerous rebound hypertension.
So, the next time you see a high blood pressure reading, ask yourself, which specific chemical lock needs turning to fix the physiological plumbing? Like, subscribe, and share this with your friends for such more pharmacy-related informative videos. Be sure to write your questions, suggestions, and thoughts in the comments section. We will catch you in next one.